NICE, the National Institute for Health and Care Excellence, updated its guidelines in 2016 on the assessment and diagnosis of recent onset chest pain or discomfort of suspected cardiac origin. Here is a brief summary of the key points. For patients presenting with acute chest pain, immediate management of suspected acute coronary syndrome (ACS) includes administering glycerol trinitrate and aspirin 300 mg. NICE does not recommend giving other antiplatelet agents, such as clopidogrel, outside of the hospital. Oxygen should only be given if oxygen saturation levels are below 94%. An ECG should be performed as soon as possible, but transfer to the hospital should not be delayed even if the ECG appears normal. Referral guidelines are as follows. For patients with current chest pain or chest pain in the last 12 hours with an abnormal ECG, emergency admission is recommended. For chest pain occurring 72 hours ago, referral to the hospital on the same day for assessment is advised. For chest pain that occurred more than 72 hours ago, a full assessment with ECG and troponin measurement should be performed before deciding on further action. In terms of oxygen therapy, NICE suggests not routinely administering oxygen, but monitoring oxygen saturation using pulse oximetry as soon as possible. Supplemental oxygen should only be offered to individuals with oxygen saturation levels below 94% who are not at risk of hypercapnic respiratory failure. For people with chronic obstructive pulmonary disease who are at risk of hypercapnic respiratory failure, a target oxygen saturation level of 88–92% should be aimed for until blood gas analysis is available. For patients presenting with stable chest pain, NICE defines anginal pain as constricting discomfort in the front of the chest, neck, shoulders, jaw, or arms precipitated by physical exertion and relieved by rest or glycerol trinitrate within about 5 minutes. Patients with all 3 features have typical angina, those with 2 features have atypical angina, and those with 1 or none of the features have non-anginal chest pain. For patients in whom stable angina cannot be excluded by clinical assessment alone, NICE recommends the following steps. For those with symptoms consistent with typical or atypical angina or ECG changes, the first line of investigation is CT coronary angiography. If necessary, non-invasive functional imaging should be considered as the second line, looking for reversible myocardial ischemia. If further investigation is required, invasive coronary angiography is recommended as the third line. Examples of non-invasive functional imaging include myocardial perfusion scintigraphy with single photon emission computed tomography, MPS with SPECT, stress echocardiography, first pass contrast enhanced magnetic resonance, MR perfusion, and Amsiter imaging for stress-induced wall motion abnormalities. For more detailed information, please refer to the provided link.